Thank you for the invitation to give this talk, and I will talk quite a bit about exercise intervention in the management of multiple sclerosis. If I can move forward. There we go. So I've structured this presentation in 4 different areas. First, the area of the early history of application involving exercise in people with multiple sclerosis. Then moving on to a period of concern in the application of exercise training, followed by a very recent period of discovery and really advanced acceleration about what we know, and then talking about major opportunities and next steps, particularly in the clinical use of exercise in people with multiple sclerosis. So let's start with the early history of application. So I'm sure many of you have seen this book, Multiple Sclerosis, The History of the Disease, and many of you have read this book. And it's a wonderful book that provides an overview on the clinical history of multiple sclerosis, such as the first patient or on the Charcot lectures. One of the other things that you might have noticed is that there is much discussion on the early clinical application of exercise in the management of multiple sclerosis, and I'd like to share with you some of these excerpts. So this is one of the very important experts. There was, along with a diminution of muscle power, he could walk a considerable distance, though he did so with a feeling of insecurity and unsteadiness, but he could not, in the smallest degree, perform such motions as are required for running, leaping, or even very quick walking, something that we often might think about when we think about exercise in a patient with multiple sclerosis. He was in other aspects in good health. Various remedies were employed without benefit. Evacuations and spare diet seemed to be rather harmful. He was continued in his state, which I've described, for about 2 months, when he determined to try the effect of violent exercise. For this purpose, he walked as hard as he was able, 5 or 6 miles in a warm evening, and returned home much fatigued and considerably overheated. Very, very normal responses to someone who would go walk 5 or 6 miles on a warm evening at a very, very vigorous pace. Many of us would be a little hot and sweating, and many of us would be very fatigued. Next morning, he had severe pains in the calves of his legs. Again, you go walk 5 to 6 miles, you're going to have some soreness in your calves. But his other complaints were much diminished, and in a few days disappeared. A normal response to engaging in exercise training when someone has been physically inactive. We have these acute problems that disappear in a short period of time. He has ever since enjoyed very good health. I think this describes a lot of what we see with exercise in the general population and multiple sclerosis. Another excerpt. This is a case from Hammond. He found little hope for therapy preventing the formation of further islets of inflammation and sclerosis and regarded the condition as unamenable, as far as we know, to medical treatment. But interestingly enough, in addition to a variety of approaches, using things like strychnine as an example, he recommended 2 glasses of wine daily and moderate exercise, something that we oftentimes, when we go to a physician, I don't have multiple sclerosis, we hear being recommended to us for maintaining health. The last is this excerpt about a variety of different measures being used at Salpêtrière. And exercise, first thought to be harmful, had become a treatment modality by the end of the 19th century, although neurologists cautioned against excess effort. And I bring these excerpts up because oftentimes we think that the study of exercise is something relatively recent, and the application of exercise is something that we've only started to think about in the past 5 to 10 years. But rather, the application of exercise has been something that has been long occurring in individuals with multiple sclerosis. So there was a period in which there was much caution about the application of exercise in people with multiple sclerosis. And this can be attributed back to Wilhelm Uhthoff, who discovered the blurring of vision with exercise. Uhthoff collected 100 cases of multiple sclerosis when many felt that it was a rare disease. He detailed the ocular and visual changes in the disease. He is remembered most for the observation that exercise can cause the vision to transiently decrease. And what's interesting about this is that if you actually look at these 100 cases, there were actually only 3 cases of individuals with multiple sclerosis who developed these transient visual symptoms with exercise. So whether or not we want to call this a major occurrence is open to debate. In 1921, the Association for Research in Nervous and Mental Diseases had a meeting on multiple sclerosis. And they came away with advice. And these were 3 of the prominent pieces of advice. One is that people with MS should avoid pregnancy. Another is that they should avoid heat. And the third is that we should avoid heavy exertion, i.e. exercise and physical activity at too high of an intensity. And I think we'll want to come back to this at the end because Professor Giovannoni and I were talking about high-intensity interval training and whether or not this might be beneficial in people with multiple sclerosis. So the era of discovery. This is a rather exciting period of time. And it really started with the first study by Randy Shapiro. And he did this study and published it in 1988 in the Journal of Neurorehabilitation, which is now Neurorehabilitation and Neural Repair. And what he did is he had individuals, 50 with clinically definite multiple sclerosis. 25 of them did aerobic exercise training. And 25 of them were not assigned to exercise training. And they studied the effects of this on aerobic fitness and also disability progression. And what they found is that aerobic exercise, when performed appropriately, I'm not quite sure what that means, but we'll come back to that, does not increase disability. That is, in this trial, the individuals who engaged in aerobic exercise training did not have a worsening of disability status as measured by the expanded disability status scale. There was a modest increase in fitness, which was measured by the amount of work that an individual could do during a maximal incremental exercise test. This is a common measure of aerobic power. Interestingly, low disabled individuals tended to become more fit more easily than the high disabled individuals. And this speaks to response heterogeneity with exercise training studies. That is, there are some proportions or segments of the MS population who don't respond as well. Maybe that's because they can't undertake an appropriate volume of exercise, or maybe that's because they don't adhere to exercise appropriately, but we'll come back to that as well. Moving forward was really what I would consider a landmark study. This was a study by Jack Pettijan and Ed Gatmeyer. This was actually, most people don't know, Ed Gatmeyer's dissertation project, where they looked at the effect of aerobic training on fitness and quality of life in individuals with multiple sclerosis. And one of the things that they wanted to do in this study is to challenge the idea regarding the safety of applying high-intensity aerobic exercise in people with multiple sclerosis. So at the time that this study was done, they put together a training stimulus that was 15 weeks, where individuals did training 3 times per week for 40 minutes per session with arm and leg cycloergometry. And these individuals exercised up to 85% of their peak aerobic power. That is a very vigorous intensity stimulus. What they found is, compared with baseline, the exercise group improved their fitness, they improved strength, they lost body fat based on skin fold measurements. There were some changes in triglyceride and very low density lipoprotein levels. There also were changes in psychological profile, particularly depression and anger scores, and fatigue was reduced. And so this was the first real study that began to show that the benefits of exercise surpassed just improvements in fitness, which we would expect with exercise training, but pertain to other areas in people with multiple sclerosis. I'm going to skip this study in the sake of time, and then look at what has happened. So the first study by 1988 actually didn't even register on a PubMed search using the terms exercise training or physical activity with multiple sclerosis. The Pettijan study started to create a little bit of a blip on the radar. We had a Barry Oaken study that I decided to skip in 2004, and then all of a sudden, in about 2007, 2008, there was a dramatic increase in the number of studies being published on physical activity and exercise training in people with multiple sclerosis. And I think the story that is emerging out of this is quite interesting. So some time back, we tried to organize this body of research. That is, we tried to use the ICF framework as a model for understanding MS pathogenesis, changes in body structures, body functions, activities, and participation, and tried to classify the extent to which physical activity behavior, particularly exercise training and lifestyle physical activity, might exert effects in these different buckets of outcomes. When we did this study, there were very few, wrote this paper, there were very few studies looking at exercise and inflammatory markers and neurotrophic factors. There further were very few studies looking at body structures, particularly axonal damage and loss or neuronal loss. The vast majority of the research fell within these four buckets. And what this research is showing is that exercise training generally improves aerobic power, that is, individuals have an improvement in aerobic capacity, as well as an improvement in muscle strengthening. Those in turn seem to be associated with improvements in walking performance, whether that's measured by the time 25-foot walk or the 6-minute walk. I believe there are even some data on the multiple sclerosis walking scale based on a perceived walking. There are improvements in balance as well. There further are reductions in fatigue and depression. That is, with aerobic exercise training and resistance training, fatigue seems to decrease and depression decreases. We also see an improvement in quality of life. Now, those are based on meta-analyses, and looking at systematic reviews, we actually see that there's evidence for physical activity and exercise reducing the rate of relapses in people with multiple sclerosis. Related to Ruth Ann Marie's talk on comorbid conditions, there are data that suggest that exercise training and physical activity reduce cardiovascular disease and metabolic comorbidities. There are some emerging data that exercise can improve cognition, it can improve health-related quality of life, and it can improve participation. That is, the extent to which individuals can actively engage in everyday life tasks, such as recreational tasks, leisure tasks, and the ability to maintain employment. So this is an overview of exercise safety. And this is a paper published by Lara Paludi. And she looked at all the randomized controlled trials to try to identify whether or not there was an increased risk of adverse events with exercise training in MS. One of the outcomes that she looked at was relapse rate. And she found across all the studies that in exercise training conditions, the relapse rate was 4.6%, versus the control condition, the relapse rate was 6.3%. That seemed to be associated with a 27% reduction in the rate of relapse with exercise training. When she looked at adverse events, the rate of adverse events was 2% in exercise training versus 1.2% in the control conditions, and that was associated with an increase in the relative risk of adverse events. This increase in the rate of adverse events is actually lower than what you see in the general population who engages in exercise training, suggesting that maybe individuals who are designing aerobic or resistance training programs in people with MS are doing so keeping safety in mind and trying to do so to reduce the likelihood of individuals being injured. She also looked at the dropout rate, which is interesting in that there is about a 15% dropout rate from exercise training studies in exercise interventions, and the same with control conditions. So a lot of people are completing these studies, and this is actually, these dropout rates are lower than the general populations. So exercise seems to be safe from this review of the literature. So with all of the research in mind, Amy Latimer Chung and Kathleen Martin Guinness put together a group of individuals to try to create exercise training guidelines for persons with multiple sclerosis. And what they did is they first started with an extensive review of the literature to identify what is the actual evidence that exercise can have benefits in people with multiple sclerosis. After looking at this literature, they then devised guidelines for the prescription of exercise. These guidelines were then vetted for whether or not they were suitable. That is, the guidelines were sent out to a large number of people with multiple sclerosis. They were sent out to a large number of clinicians, and they were vetted through other stakeholders to make sure that the guidelines matched the evidence consistently and the guidelines were clear. And everyone seemed to agree, and these are the guidelines. And I'm going to go through these quickly. You can find them if you're interested by looking for Canadian Physical Activity Guidelines for MS. These are not specific for Canadians. It's just that's what they were published under. So aerobic exercise is supposed to be performed 2 days per week. That is, 2 times per week an individual should engage in aerobic exercise. They should also engage in strength training exercise 2 times per week. These don't have to be performed on separate days of the week, so in that way, an individual can do aerobic and resistance training on the same day. The only requirement is that those days of exercise need to be separated by 24 to 48 hours so that you avoid residual fatigue creeping in. The aerobic exercise should gradually increase to at least 30 minutes during each session, so starting very low, 5 to 10 minutes, and gradually increasing up to 30 minutes and beyond. The strength training should start with a number of repetitions that an individual can lift safely and progressively increase to 10 to 15 repetitions as one set, and ultimately getting 2 sets of 10 to 15 repetitions each one of these sessions. It should be moderate intensity for aerobic activity, and one of the ways to determine this is the breathing test. That is, if an individual is engaging in aerobic exercise, it should be hard enough to where they cannot keep on a simple and prolonged conversation, but it should not be so hard that they are out of breath and can't hold on a conversation. The resistance exercise should be hard enough that they can finish 10 to 15 repetitions safely. And how to do it? Some of the options for aerobic activity included upper body exercise like arm ergometry, lower body exercise like walking or cycloergometry, or a combined device like an elliptical trainer. With strength training, the recommendation was weight machines, free weights, and cable pulleys. There was some suggestion that these other types of exercise might work, like using elastic bands, aquatic exercise, or calisthenics. Now, with all of this evidence in place, the question becomes, are we moving the needle? That is, are we changing the face of exercise and physical activity participation in people with multiple sclerosis? And unfortunately, the answer is no. That is, people with multiple sclerosis are about a standard deviation less physically active than the general population. And this is mostly based on studies in the United States. And we all know that people in the United States are generally physically inactive, and people with MS are 1 standard deviation less physically active. That is a major problem. We further know that this rate of physical inactivity has not changed over the past 25 years. So we don't seem to be moving the needle. So what are our opportunities and next steps? So I was fortunate to put together a paper with Brian Sanderoff, Kurt Kwakle, Ulrich Dahlgrith, Peter Fays, Chris Heeson, Anthony Feinstein, and Alan Thompson, where we were interested in trying to figure out what are the major problems with the literature that might be affecting knowledge translation and ultimately moving the needle. And this paper is published in Lancet Neurology if you're interested in it. And we came up with 4 major themes. One has to do with the strength of the existing evidence. The second has to do with scope of evidence. The third has to do with mechanisms supporting the benefits. And the fourth has to do with a clinical or a conceptual framework and toolkit for translation, i.e. the resources for putting this into place. So let me start with an example of the strength of evidence. So this is a meta-analysis published by Lara Paludi, and it's a meta-analysis looking at the effects of exercise training on symptomatic fatigue in people with multiple sclerosis. And you can see that there are quite a few studies that have looked at the effects of exercise training on symptomatic fatigue. You can also see that there's a great deal of variability in the average effect size across these meta-analyses. The average effect is about a half standard deviation improvement in fatigue. That is, with exercise training compared to controls, there is about a half standard deviation reduction. And this translates to about a 1-point improvement in the fatigue severity scale score, which is enough to help someone become or move to a state of not having severe fatigue. So what's the problem? Well, when you look at these studies, not a single one of them pre-screened and recruited individuals with multiple sclerosis who actually had fatigue. So a priori, these studies were not designed to look at how exercise actually can be used to treat fatigue. So it's suggestive that exercise might be beneficial, but it would be better if we had individuals who actually were pre-screened for the presence of elevated fatigue. The same can be said for depression. Here are a great deal of studies that are actually of pretty good methodological quality that show about a 1/3 standard deviation improvement in symptomatic depression with exercise training. The problem is, again, none of these studies have pre-screened individuals and recruited them to have clinically relevant fatigue in these trials. So what this suggests is we have lots of evidence on the benefits of exercise training, but none of it is relevant for treating actual problems in multiple sclerosis at this point in time. Another problem is the scope of the evidence. That is, this is a recent paper by Byron Lai looking at the characteristics of adults with neurological disability recruited for exercise trials. And this is the summary for multiple sclerosis. You can see that a lot of the studies include very small sample sizes. So in these studies, we're examining the effects of exercise in probably very underpowered samples. We further look at these studies and we look at the racial ethnicity, we can see that 82% of the samples are Caucasian. We have very little information about the effects of exercise outside of the Caucasian population. We can see that 74% of the individuals are female. So we know very little about the effects of exercise on males with multiple sclerosis. Many of these individuals, almost 80%, have some degree of college education. We don't know anything about how to study exercise or the benefits of exercise in less educated individuals. Some of these other problems are that most of the studies include people with a very short duration of disease. The majority of the studies include people with relapsing and remitting multiple sclerosis, not progressive MS. And most of the studies include people who don't have significant disability. I would say another problem with these studies is that most of the studies pre-screen individuals who have no contraindications for engaging in exercise training. That is, they are very, very healthy samples, and Ruth Ann Marie showed us very clearly that comorbidity, particularly physical comorbidity, is quite rampant in multiple sclerosis. So again, it makes you wonder about the generalizability of this literature. Another big issue is the putative mechanisms. That is, how is it that exercise is exerting any effects? Leslie White put together a very comprehensive table on the potential role of exercise in attenuating disability and enhancing quality of life, potentially through brain health, potentially through functional benefits, and potentially through immunomodulation. But when you look at the actual data looking at immunomodulation and exercise training, the data are inconclusive at best, probably more likely non-supportive, looking at exercise and anti-inflammatory and pro-inflammatory markers. This is a recent paper put together by Brian Sandroff and published in Neurorehabilitation and Neural Repair. And this paper is trying to understand what is it about exercise that could be the real explanation for central nervous system benefits. And what Brian suggested is exercise is a very, very, very powerful stimulus. That is, when someone exercises, it activates nearly every sensory system in the human body. That sensory information is coming back to the central nervous system and being processed. And it's being processed by a number of brain regions. And when it's first coming back to the central nervous system, it's being processed in a very non-efficient manner. And because of that non-efficient manner, the motor output and the consequences of exercise very early on are poorly regulated. Over time, this process becomes more efficient. That is, the sensory input that's coming back to the brain and being processed is resulting in better connections and stronger connections with major brain areas, and that is improving motor output. And ultimately, the exercise-related sensory input is resulting in a more efficient neural process that is associated with more efficient motor control and other outcomes in multiple sclerosis. The last issue comes with, what do we actually do when we think about clinical recommendations for getting people with multiple sclerosis to exercise? And over the past 5 years, we've been spending a lot of time trying to create a conceptual model that allows for exercise promotion in the context of the patient-provider interaction. And that idea came up earlier, that the providers could be one of the initiating points in changing exercise behavior in people with multiple sclerosis. But I believe one of the comments also was that providers don't have a lot of time, and we have to think about practice models. Well, what we've suggested is that part of the problem as well is preparation. That is, providers don't have a lot in the way of education and training in exercise for multiple sclerosis. So part of the solution is that we have to work behind the scenes here in preparing our providers with service training, professional training, and protocols that can be put in place to promote exercise in the patient-provider interaction. The second part of this is in the action adoption stage. That is, that during the patient-provider interaction, there needs to be some degree of preparation. That is, a provider needs to know about the current exercise behaviors of an individual with multiple sclerosis, as well as other important pieces of the story. There needs to be this consultation between the provider and the patient, particularly the neurologist. At least in the United States, we find out and we hear that our patients really would like to hear about exercise from the neurologist, but then the actual putting exercise in place has to occur with referrals, that the neurologist is not the person to per se execute this program, that instead it needs to be the nurse practitioner, a PT, an OT, or other rehabilitation professional. And then we need to actually put exercise in place. In doing all of this, we believe that you can actually move this major problem where 80% of people with multiple sclerosis are inactive and start to shift them to the other side and maybe move the pendulum a bit in the world of multiple sclerosis. So I want to close by recognizing that exercise may indeed be powerful medicine. But the question is just how powerful. I don't think we know that story just yet. But I will say that in other areas, this paper by John Ioannidis has suggested that exercise and many drug interventions are potentially similar in terms of the mortality benefits. Now, that isn't the same as multiple sclerosis, but they're equating based on epidemiological evidence the potential for exercise and drugs. Given the scarcity of financial resources to fund future trials of exercise interventions, one option would be to require evidence from pharmaceutical companies that are under increasing pressure to perform active comparator trials for market entry. They're actually suggesting that exercise becomes the new control condition. If a disease-modifying drug cannot have a larger effect than exercise, they're suggesting that this needs to be taken into account. There are lots of questions that still need to be resolved, and one of them that we heard about earlier is what are the effective approaches for physical activity behavior change, and that will become very important over time. And more we're seeing societies, this is the National MS Society in the United States, getting behind exercise as a wellness approach for people with multiple sclerosis. So I will stop there and take questions.